Case-based discussions for every case, for every session, there will be a case, and I will show some of the views or multiple views of this case, just to train your eyes on the abnormals, because you can go and proceed with normal views, but you have to be trained also in the abnormals. So the concept is learn as you go. It's shared discussion between you and me, so it is not a YouTube video, so it's not one-way discussion. I will stop at certain stages and get the feedback or questions from your side, and that's why it's a webinar. One view per lecture in the first 4 or 5 lectures to build up your experience. Then we may go more complex or more complicated after that. I have to declare that I have no conflict of interest with any companies. This is our case-based discussion. 65-year-old obese man presented with just history of prostate cancer, and he presented to our emergency department with shortness of breathing, hypotension. Fluid bolus given, he is still hypotensive. What do you think about differential diagnosis in this case? Hypotension and shortness of breathing, maybe pneumonia, maybe pneumothorax, maybe prostate cancer mets with sepsis and septic shock. Maybe because he's a cancer patient, it's DVT and pulmonary embolism because he's a high-risk category. So before I put my probe on the patient, I have to have differential diagnosis. So it's history, examination, investigation. I'm not saying that ultrasound or echo can replace the history or examination. You have to build up step-by-step approach. So we, after history and examination, we found no positive finding enough to rule out other diagnoses. So we did a bedside ultrasonography or echocardiography using the phased array probe. First of all, you have to do eyeballing to see if there is any chronic cardiac problems. The apical before chamber view was a bit difficult, so it is optimized by overall gain, time gain compensation. Then we had a right ventricular dilatation identified. We used the color Doppler upper tricuspid valve to demonstrate how much flow on the tricuspid valve or regurgitant flow. Then continuous wave Doppler was used to see and calculate how much is the pulmonary artery pressure or systolic pulmonary artery pressure, raising the concern of pulmonary embolism. Then the pulsed wave Doppler on left ventricular outflow tract to see if this patient is a fluid responder or not, using passive leg raising test, which will be more accurate in this scenario than the IVC diameter and the index, because there is signs of pulmonary embolism, so I shouldn't use IVC diameter and the index in this scenario. Factor that controls the image quality is you yourself and your level of training. Second factor is how much time you dedicated to do this ultrasound. So you may do a quick exam 5 minutes, or you may do fully detailed exam in 25 to 30 minutes. And after this full assessment, you can build up with repeated exams and follow the trends. So patient challenges, like patient position. Sometimes patient is prone for ARDS. If the patient is on mechanical ventilation, particularly if he's on high PEEP. Some patients are really non-echogenic or obese. Some patients had adhesive taps on the site of ultrasound. These are challenges. I need you to have a look here on those patients. So this is average body build up to high body mass index or slim patients. So when I should put the probe in each of these patients, the more slim the patient, the more towards the sternum you apply your probe. The more obese or high body mass index, the more you go to the axilla to find the apex. That's a kind of trick, you need to know that. The machine. What kind of gear you are using in your unit? Is it an ultrasound machine with an echo software or an echo machine? So this makes a great difference. I may go from simple machines, which is handheld devices, very commonly used nowadays, to that sophisticated gear and high technical machines, so you can have good software, you can have 3D, you can have this advanced echo. Most of us don't have either of those, so let's try to make it simple for us. First of all, check your transducer, what kind of transducer you need to use. Attach the transducer to the machine if you have multiple transducers before you switch on your machine, because if you do that while the machine is switched on, you may do harm or damage to the probe or the motherboard of the probe. So always switch on the machine after connecting your probe. After you switch on the machine, you will find the first screen comes to you is the patient details. I do advise you to always put the patient details and press the record button. So you have your log, you have to have your logbook and recorded cases and progress and monitor your progress during this training. Choose a suitable preset of the machine, and we'll see how to preset our device now. Adjust the depth to center area of interest. So if you are doing lung scan, is different from fast scan, is different from cardiac scan. So for example, if I need the 5-chamber view or 4-chamber view, which we'll see today, you need to bring at least 15 to 16 centimeters of depth. While if you are doing lung scan and you're searching for pneumothorax, 6 centimeter or 7 centimeter will be enough. So you need to know that, and we'll pass by these points as we go. So optimize the goal. So what is the gain? Optimize the gain, sorry. What is the gain? There is overall gain and time gain compensation. The overall gain is the same as sound amplifier. When the sound is coming to you at a low tone or low voice, you increase the amplifier, so you increase the whole sound waves reaching the machine. While time gain compensation, there is lateral and axial, and we'll proceed with that in the next few slides. Then adjust the frequency. Frequency is mainly probe related. So the probe is 1 to 5 or 7 to 8 or 7 to 12. It depends on the probe you use. But still, if you decrease the sector size, you are increasing the frequency. What's the value of increasing the frequency? Increasing the image quality. So resolution is directly related to the frequency. The more frequency you use, the better the resolution and image quality you get. But it is not hassle-free. There is a disadvantage behind that. Then adjust the focus. Focus should be just deeper to the area of interest. So if you are measuring the valve area, the aortic valve area, put the focus on the sector just below the aortic valve. And that's really important to get the best image at this focus. And again, if you adjust sector width smaller, you will increase the frame rate and resolution of the image. So you have to know what are the basics of ultrasound imaging, and the idea is you can see the sound, not only hear the sound wave. So how you see the sound, you know, what is echo? Echo is I'm sending sound, hits an object, and comes to me back as a reflected sound wave so I can hear it. So I have to send the voice or send sound waves, and then it comes back to my ear, and then I can perceive with my ear. It's the same as you send electricity or electrical waves to your ultrasound probe, and the ultrasound probe can change the electrical waves from electrical waves into sound waves, which will hit the organs, and then it comes back. And when this image, okay, so at this moment, when the sound wave hits the heart and comes back, it is hitting the probe, which is the piezoelectric fibers, and then makes the image. So the idea simply is sound generation through the piezoelectric fibers of the echo probe. Then, when these ultrasound waves hit organs, and when these sound waves hit the organ, it comes back after some changes with the tissues, and then change back to image so you can see the sound. Hearing is regularly in 20 Hz, while the ultrasound waves megahertz, so we cannot really hear that sound wave. The higher the frequency, as we said, the higher the resolution. But the problem is it is lower penetration, and we know why that in just a couple of minutes. Frequency is a function of transducer, and the resolution means how or what is the ability of my machine to discriminate between 2 points, either in axial on the left image or lateral in the right image. How I can control that? With axial and lateral TGC or time gain compensation. Simply, I can advise you, if you have good machine or highly advanced or moderately advanced machine, you can use the eye scan or the tissue harmonic imaging if you have this option in your machine. The basic principle of the 2014 guidelines in ultrasound imaging use ALARA technique, which is as low as reasonable achievement. So use the minimum amount of ultrasound exposure to the patient. So use your technique as fast as you can. Use your exam as fast as possible. Don't expose the tissue to high ultrasound image, despite it is known to be safe, but not on all tissue. So if you are doing an eye exam, the few seconds will be more than enough. Just put the probe, acquire the image, remove your probe. This is if you are doing an ultrasound exam. And the same with other tissues, but with less importance or less stress on this. So depending on the reflection of ultrasound waves, your image will be hyperechoic, which is bright image, hypoechoic, which is dark image, or anechoic, which is jet black image. Attenuation is a result of 5 or 6 factors, and we need to go through this in detail. On the left image, on the left side image, you have transmission. If you are perpendicular to the tissue, and there is 2 tissues with different acoustic power. So the tissue up and the tissue down with 2 different acoustic power. And from this one, 100% of the waves transmitted down. So when it hits the tissue, it comes back and hits the probe. And then you get 100% of the ultrasound wave you send to the tissues, which never happens. Part of this one is in second image, which is reflection. And this depends on the angle you are putting your ultrasound probe on the tissue. So the more angle, the lower the angle between the tissue and the ultrasound probe. So if it is 0 to 10, 10 to 20, 20 to 30, up to 90 is the best. The lower the angle, the more reflected waves. Refraction is another issue, which is ultrasound waves that pass to the tissue, but not straight away after the probe. So again, it is distracted away from the probe and does not come back. Absorption is amount of waves that can come back, absorb it in the tissues as heat. And scattering is the last one. So you can have attenuation of the image because you lose the sound energy with these 4 or 5 ways. So reflection, refraction, absorption, and scattering. And as you see on the image on the right side, the most important is reflection and refraction. This is the most 2 lost energy. What is refraction? Let's have this simple test. Take a cup and coin test, and you put the coin here at the bottom of this cup and move it so you cannot see the coin now. Same level, you start to put water in this cup of water, and you can see the edge of the coin gradually. Now you see half of the coin, and when this cup is full of water, you can fully see or visualize the coin. Is that clear? So the gray arrow here is the light wave hitting the water, and if it comes straight away back with the gray arrow above the level of the water on the right side, you will find that you cannot see because it does not hit your eye. Here, can you see the arrow now? I hope you can see that. So if light wave is coming and hitting the coin here and it's reflected without any change in reflection or refraction, it shouldn't see your eye here. This light shouldn't reach your eye here because it's coming from here to here and you cannot see it. But when you add the water here, what happens? It hits the coin, and in its way back, it's different surfaces between air and water. So 2 acoustic speeds or 2 acoustic powers. So refraction happens, and you can see the coin here. So initially it was only air. You cannot see the coin because it's directly reflected. Here, because of refraction, you are able to see because you added water. I hope that's clear. So that's why the higher the frequency, the lower the penetration, because attenuation that happens equals the attenuation coefficient multiplied by the depth of the tissue. So the deeper the tissue, the more attenuation, and the deeper the tissue, the more attenuation coefficient, and this attenuation coefficient is also directly proportional to the frequency of ultrasound force. So attenuation depends on 2 points, not only one. First is the depth of tissue, which may happen with any probe, with any tissue. So the deeper the tissue, you find that the image quality is a bit more poor or worse as you go down far in the tissues. But what is not clear, why the higher frequency probe shows low penetration, because the higher the frequency of the probe, the more attenuation coefficient, the more attenuation of image, so cannot penetrate into these tissues. Now, what are the modes that we have? So, two historical modes, which are B mode and A mode. I'm not going to talk about that because it's just theoretical. We are not in need of that in the modern ultrasound machines. 2D mode, which is the mode we use initially with every ultrasound machine. You can see the image of the tissue. And M mode, which is a motion mode. So the x-axis is time, and the y-axis is the movement of tissues over this time. So, for example, I am putting this line perpendicular. Once you hit the M mode button on your ultrasound machine or echo machine, you get this line. You adjust this line so it hits all the tissues in different points. So the first thing, it hits here, and then here, and then the valve or part of the valve, and then this wall. This is the parasternal long axis view in echo, and this is an echo probe. Once you hit this M mode, it makes you this line first, and once you hit the M mode again, it brings you this image down. So the first thing I hit the RV wall, which is here, and then the septum, which is here, then part of the mitral valve, which is here, then posterior inferior wall of the left ventricle, which is here. So this is the parasternal long axis view, and this is M mode. This is the same mode I'm using to measure the inferior vena cava, and anytime you are trying to measure a diameter, please be perpendicular to the walls you are trying to measure, because if you go slanted like that, it will increase the diameter, because if you measure from here to here, for example, it's 3 centimeters. If you go from here to here, you will find it 3.5 or 3.6. That's why you need to be perpendicular to whatever you are measuring. This is important with M mode. Then Doppler, and we have 4 types of Doppler: color Doppler, pulsed wave Doppler, continuous wave Doppler, and tissue Doppler. What's the difference and when I can use every one of them? Let's go through this one. So color Doppler is a color measuring the flow of the blood. So if the flow towards your probe, that means red color. If the flow is away from your probe, it is blue color. So what this blue means? It is blood flow away from my probe because my probe is sitting here. What does this mean? If this is during systole, and I can mark that during the ECG, there should be no flow during systole on the mitral valve. This is the 4-chamber view on the heart. So this is left ventricle, left atrium, right atrium, and right ventricle, and we'll go through the anatomy, but this is a discussion for later on. So at this moment, you have this flow on the mitral valve during systole, which shouldn't happen. So that means mitral stenosis. So you know that there is a mitral stenosis in this patient, and you need to assess how severe it is later on. So color is for valvular assessment mainly, and I need to know if there is any regurg. Sorry, it is mitral regurg. There is stenosis. Forgive me for that. It's a mitral regurg. If it's systolic, so there is systolic flow on the mitral valve, so there is mitral regurg. If it is diastolic flow, and if it is in red, so it is normal filling. But if it is during diastole or in diastole, and there is high gradient or mosaic flow, which is the difference between the blue and red is mosaic appearance, or like this color, mosaic appearance. That means high flow. This high flow indicates mitral stenosis. So we use the color to see if there is any valvular heart disease or stenosis or regurg, even with no valvular heart disease. Okay. So pulsed wave Doppler is a kind of Doppler. Doppler is using the speed of sound at certain areas to judge the flow. So pulsed wave Doppler, as you see in this figure, I am opening this gate, which is a line going here on the aortic valve. This is the aortic valve, and I'm putting the gate just below the aortic valve. This is a modified, or this is apical three-chamber view, and this is just below the aortic valve in the LVOT, left ventricular outflow tract. Okay, what discriminates between the pulsed wave and the continuous wave is this gate, the small two parallel lines. If it opens two parallel lines in this one, that means it's pulsed wave. If it changed to a diamond shape or rectangle shape, like in this one, this is continuous wave. So let's discriminate between pulsed wave and continuous wave. Okay, the difference between this gate. You have to open this gate through setup in the machine. It's just a button to move it right or left, or clockwise or anti-clockwise, to get the least possible value, 0.5, and put it. The problem with the pulsed wave Doppler, it measures your blood flow at a point. So you are pointing this gate just below the valve, so it measures your blood flow or the speed of your flow at this point. So at this line and in this point, particularly or precisely. While in the continuous wave, that's why you find this wave is just a line. It's a thick line, but it is just a line. So there is nothing filling this wave from inside, because you are measuring the time, flow over time at a point. But when we go to continuous wave Doppler, I don't know what is this view, but it's a transesophageal echo, okay, because this map means transesophageal echo, and this is continuous wave because this diamond shape or this modified rectangle, and you see it's full wave. So you can know that is it pulsed or continuous wave from the shape of the wave. The whole wave is full from inside. What's the difference in our utilization? Pulsed wave Doppler is very precise, but the problem with it, it cannot give you high speeds. As you see here, the maximum here you can see is 140 centimeters per second. So it is designated for low speeds of flow. So if I have high flow or high speed, like in moderate or severe tricuspid regurg due to acute pulmonary embolism, which is a concern for us, and you find speeds up to 450 and 500, you cannot use the pulsed wave Doppler in this one. You have to use like this one. Can you see here? This is 600 centimeters per second. This is very high velocity. You can't use pulsed wave Doppler for that. So you have to use the continuous wave. So what's the problem here with the continuous wave? It measures the flow all over your line, okay? So all over your line. But you can know from multiple exams what is the highest speed, because if you are putting that on tricuspid valve, for example, and there is no other pathologies on this line, you know, you presume or you suspect that this is coming from this point. But again, this velocity is full wave, closed from inside, full of flow, because it gets flow all over this line. It's not only in this point, but it can give you high speeds. So for left ventricular outflow tract VTI, we cannot use the continuous wave Doppler. We have to use the pulsed wave Doppler. Okay, that's a requirement. Okay, so now what is the tissue Doppler imaging? Tissue Doppler imaging is another modality, but does not measure the speed of the flow of the blood, which was in pulsed wave and continuous wave. No, it measures the speed of tissue. So it measures how much the tissue is advanced or going front or back in front of your probe. So I'm putting this gate here on the septum or the mitral insertion point or in the interatrial septum, and measuring how the tissues move towards or away from the probe. So this is the tissue Doppler imaging, and I need the 4 of them to get proper echo image on my patient. So you cannot do full echo without this one if you need to do hemodynamic assessment by echocardiography. So when you are buying a machine for yourself, you have to have Doppler, and if you are keen to get the pulmonary artery pressures as a surrogate of left ventricular outflow, left ventricular filling pressures, you have to have tissue Doppler imaging in this machine. So you have to ask about that. Okay. So the probe movement, we need to know, or we have to have a common language. So when I ask you to do something with the probe, Walid, can you just repeat? So now these are the probe movements, and it's essential to have that common language. Pressure means press on the probe. Alignment, if you are using needle like in regional anesthesia techniques. Rotation. Rotation, which is either clockwise or anti-clockwise. So I can say rotate your probe 30 degrees clockwise or 90 degrees anti-clockwise, and this is a common term used. And the last one is tilt. And tilt is the most confusing one. So tilt is either kepalad or towards the head, or kodad, which is towards the feet. And when we are talking about the ultrasound beam. Have a look here. That's my ultrasound beam. Here, when I ask you, can you see this image? I hope so. 1 second. Now, when I ask you tilt towards the head, that means you have to tilt the beam of ultrasound towards the head. That means the tail or the wire of the probe going towards the head. That's why most of people confused. So when I ask you tilt toward the feet, that means ultrasound probe is going towards the feet, like that. So the tail or the wire of the probe is going towards the head. So when we talk, we are talking about the ultrasound waves. Forget about the tail, forget about the probe, forget about the wire. I'm talking ultrasound waves. So I'm asking you, tilt your probe towards the head, tilt your probe towards the feet. Is that clear? I hope it is. Okay? Tilt the probe towards the head means ultrasound waves are going more kepalad or towards the head. So tilt towards the feet means towards the feet with ultrasound image. Okay? This is the most confusing one. So we put that as mnemonic, which is part. Pressure, alignment, rotation, and tilt. Tilt is, for me, is the most important. Let's go anatomy, and from the anatomy we'll get the 4-chamber view and make our discussion on it today. So with this image, I hope you can see my mouse here. It's important. Yeah. So here, this is my echo probe. And when you do transthoracic echo, you are facing the apex. From this is apical 4-chamber view. And what's in your right side here, or your image right side, is actually the left side of the patient. So whatever on the right side in the image, you will find it's the left side of the patient, provided it's in the echo setup of the image quality. I'll show you that in a minute in one image. What on your left hand side is actually the right side of the patient. Okay, so let's have a look here on one of the images to make it more clear. So this is echo setup. So this PE is the green dot on your echo probe, and you are pointing this green dot to the left side of the patient. So whatever on your right side here should be the left side of the patient. Again, that's my green dot. I hope you can. 1 second to show my image, because we need to have a quick look. Okay, now this is your green dot, which is this green one, and that's my knob of the probe pointing to the left side of the patient. Imagine that's my heart. Okay, and you are screening me now. So this is the knob of the probe, and I'm getting the 4-chamber view of the heart. So what's on my right side on the screen is actually the left side of the patient. What is on the left side of the screen is the right side of the patient, because I'm just getting him as mirror image. I hope that's clear. So if you go back to this one, that's the right side of the screen. If you find the P wave on your right hand side, so whatever on the right side of the screen is the left side of the patient. So this is a muscular structure, and this is the first thing the probe hits with this chamber. So two muscular structures will be the left ventricle and right ventricle. So which is which? What's on my right side is left, so this is the left ventricle, and what's on my right side is the left. What's on my left side is the right, so this is left ventricle and right ventricle. You cannot depend on the size or the shape, because cardiomyopathic patients and congenital anomalies are really, really different. And the last thing, if you want to discriminate, is the tricuspid and mitral valve position. Most of cardiac echocardiographer and pediatric echo technicians in congenital anomalies depend on this point. So whatever near to your probe is the tricuspid valve. Can you see that one? So this is tricuspid and this is the mitral. Mitral is lower or deeper than the tricuspid. Okay, if I open you here, and I put my probe here, so this is tricuspid valve and this is the mitral valve. If you see this view, so tricuspid valve is always nearer than the mitral valve to the apex. So if you compare that to this image, I know that this is the left ventricle and this is the right ventricle. Normally, I have the left ventricle and right ventricle 60 or 65%, 2/3 of the left ventricle. And this is bullet shaped and this is triangle in shape. So left ventricle is bullet in shape, right ventricle is triangular in shape. After you hit with your probe the ventricles, you hit the atria in the back or underneath. So ventricles and the atria. Why? Because I'm coming from the apex. So apex first, then two ventricles, right and left ventricles. Hope you can see my heart. Okay. So here two ventricles because you are hitting from the apex. So left ventricle and right ventricle. Then valves, which is midway between ventricles and atria. Then you can see left atrium and right atrium. Hope this is clear. Now I will open your mics and you tell me what's abnormal in this view. Raise your hands, please, or write something in the comments. Any ideas? Yes. So Dr. Fergani says that right ventricle is bigger. So we lost that 2/3 relation. So right ventricle is bigger. So now I'm suspicious. Is it acute, chronic, acute or chronic? On chronic, so I have to go on this tricuspid valve and measure my velocity here, and you can see that it's 350 systolic pressure, and I can simply, once I hit this systolic pressure, I can see, I lost my mouse again. The pressure gradient came here at 49. So this is systolic pressure gradient on the tricuspid valve. Who can tell me, is it pulsed wave Doppler or continuous wave Doppler? I'm waiting for your answer.
It's continuous wave.
Perfect. How do you know that?
From the shape of the wave and the velocity.
Plus the gate. You can see that in this gate, it is the diamond shape or the rectangle. Okay, that's good. So with continuous wave, you found the pressure gradient, systolic pressure gradient is 49. You can add to that the right atrial pressure or central venous pressure 5 to 10. You can calculate that also with echo. So you can get a pressure gradient of 60 or 65, moderate or high moderate pulmonary artery pressure. So you can say that this is moderate or moderate to severe. Severe starts from 70 systolic pressure gradient. Okay, so this is a PE until proved otherwise, plus other signs, McConnell sign, and more sophisticated images and findings. We can discuss about that in different images. Now, who can tell me what is this view? Can anybody tell me that?
I think this is 5-chamber view.
1 second. Yeah. Good. Why you say so?
Because I can see the 4 chambers of the heart and the LVOT.
Okay, let's go back to the basics. My ultrasound or echo probe is here and T is to the right. So what should I see here first? Left ventricle and left and right ventricle, is it? And then the atria behind.
Left atria is the lead.
Here, so I saw 2 atria and ventricles are here. So what's the problem? Any guesses? Any suggestions? So this is a transesophageal view, not transthoracic. You can see this diagram here. So you hit from the back. You hit from esophagus. The echo probe here, hitting atria first because this is the TEE, transesophageal image. So I can discriminate between transthoracic and transesophageal even without this. These sometimes come in the exam, they omit this one and say what's this view. So don't be deceived. This is transesophageal because you hit right and left atrium first, and still the same rule applies because this is right side, so this is the left atrium, left ventricle, right atrium, and right ventricle, tricuspid valve, and mitral valve. Hope that's clear. Okay, this is a apical 2-chamber view. This is one of the modified views. It's kind of important in some scenarios. And this is the left ventricle, mitral valve, and left atrium. It's just far side. And here is the parasternal short axis. This is one of the best views you may get in mid-papillary. So you can see right ventricle, septum, and left ventricle. Okay. Now, any questions at this moment? You are all unmuted now. Okay, so before that, before we finish, this is the program I used on my iPad to learn the echocardiography. It is a self-teaching program. You can make use of that. So first, this is your view with the rib cage, where you put your probe. So if you want to get this apical fold chamber view with the left ventricle, left atrium and mitral valve in between, right ventricle, right atrium and tricuspid valve in between, you orient your probe knob to 3 o'clock at the position of the apex, which is usually mid-clavicular line at 4th or 5th intercostal space. Then hide the rib cage so you can find your orientation, and this is the green and red line, so you know where is the right and left. So this is 3 o'clock, so this is the right side of my probe or me. So this is left side of the patient, this is the left side of the patient, so left side here. So this is the left ventricle, right ventricle, and if you want cut section or view slice, you can see now, and if you want orientation, so you can find here left ventricle, left atrium, in between mitral valve, and this is the septum, right ventricle, right atrium, and tricuspid valve in between. And here is the descending thoracic aorta. Okay, you can optimize your view. You can use this program also. It tells you how to optimize your view. Depends on what you find. Okay. Next session will be one view at a time. So we are going on the 5 important views, which are parasternal long axis, parasternal short axis views, which is not one view, it's multiple views, and apical fold chamber and private chamber, then subpostal view. This is the program that Mahmoud asked me. Is all what I did. It's transthoracic echo with the standard view, and it's from ECV, which is the most common exam for echo in Europe. So now, okay. So now I finished my lecture. I'm just waiting for your questions.
هي من هاجي الساعة 3:30.
Any questions? Okay. So I'm waiting to hear from you what comments, even if you have no questions. You can talk one at a time. Think about this webinar or lecture. Should it continue or that's enough for now?
Yeah, should continue.
Should continue.
Should continue.
Do you think 1 hour is enough, or we should extend it 15 or 20 minutes more?
1 hour is
No problem. 1 hour is enough.
1 hour is enough.
Okay, so I think we should go again to the poll. Please, anybody who is not in our WhatsApp group, send to me by email, because all people invited here are either through email or in the WhatsApp group. So please, whoever is not in the WhatsApp group, send me an email and put your phone number so I can add you to the WhatsApp group. And I will make another poll to make a quick questionnaire and ask your opinion how we should go from the next lecture. Any comments or questions before we close?
Yes, thank you.
No, thanks.
Thanks very much. I hope you got some benefit of this lecture. Now, if you can go and find your echo or ultrasound machine,
Thank you.
familiarize yourself with the basic setup in the machine, try to record one case and post it to me or on the group, and let's have a discussion on it. If it's something interesting or even normal view. If you got a difficult view or you got and you don't know how to optimize this view, just post it and we'll have a discussion on how to optimize from this point. So just go to your machine, record the patient details, and acquire one image or one view and send it to us, or even you can do that, capture that on your cell phone, and let's have the discussion till the next week, hopefully.
Okay, thanks.
Thank you.
Thank you so much.
Thanks so much.
Thank you so much.
Now, and I hope we'll be here by next week. Thanks so much.
Thank you so much. Thank you. Assalamu alaikum.